Well, I guess that's that. Hmm.
Yeah, that looks good.
Hmm. Okie doke, let me know when you'd
Okay, we'll
like me
just
to
stop
start.
sharing for a moment, just to say. So, good morning, everyone, and welcome to the first journal club of the 2024-2025 academic cycle. It's so nice to see all of you from the community, and a welcome to our new PGY4 residents, our fellows, and care of the elderly learners. Welcome to the first journal club of the year. Regretfully, due to unanticipated circumstances, one of our presenters will not be able to present this morning. So we will be fortunate for Dr. Natasha Lane's presentation, a PGY5 co-lead resident, on pushing the boundaries of our understanding of systolic blood pressure targets in a moment. Before we start, a land acknowledgement. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory and many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, as well as the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point. For larger conversations, more concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. And so with that, I see we have 33 participants. Dr. Natasha Lane, again, our co-lead resident. Please go ahead and begin.
Okay. Mhm. Okay. I hope everyone can see my slides and hear my voice. If not, now is the time to say something. So I'm presenting a trial with a very long title. Here it is. It's lowering systolic blood pressure to less than 120 versus less than 140 in patients with high cardiovascular risk with and without diabetes or previous stroke. And this is an open label blinded outcome randomized trial. This is the publication. It just came out in the Lancet at the end of June of this year. So it's hot off the press. And it's from a group in China. So I don't have any conflicts of interest. The goals of this talk is I want to summarize guidelines and evidence regarding blood pressure control in older adults, which it's actually a lot to go through. So I will try to make it as painless as possible. And I welcome input from people who've been doing this longer than me. It's a huge body of evidence. And then go through, this is I don't know how they say it, but ESPRI, I'm going to say, trial methods and their main results, and then do a critical appraisal and assess the risk of bias in this trial, and then talk about whether I think this trial is practice changing in terms of how we manage blood pressure in older patients. So I'll start with the case. Even cases are long when we're trying to be comprehensive, but just to highlight, this is a 78-year-old lady from home. She's very mildly frail. She has diabetes, CKD, hypertension, and then an ischemic stroke 2 years ago, and mild vascular cognitive impairment. She had an echo recently and has a normal LVF with no LVH. And she's on a pretty standard list of medications. You can read them yourself. And as part of your CGS, you get a printout from the family doc showing that she just had ambulatory blood pressure monitoring. She has a mean daytime systolic pressure of 160 to 183. And you measure her blood pressure in office, and she has a standing blood pressure of 158. She doesn't have any orthostatic drop or orthostatic symptoms. And she's the perfect patient. She's doing all of the non-pharmacologic things that people should do when they have high blood pressure. So all right, we're going to focus on medication in her. And I want you to think about, you can answer to yourself. I think our answers would be similar. But what would you recommend to her pharmacotherapy in terms of changes as part of your overall medication management? And what blood pressure would you target? What would you write to the family doc they should titrate to after you start something? So there are guidelines for this. We follow them. The Canadian guidelines came out in 2020, and they would suggest that for a diabetic patient like ours, the target would be less than 130 on 80. If someone has their post-ischemic stroke, it would be less than 140 on 90. But the more aggressive target in her per the guidelines would be the 130. And then she is not for the sprint target of less than 120, even though she has multiple cardiac risk factors, because she has a stroke and diabetes in her past medical history. I just want to bring up these are Canadian guidelines. We love Canadian guidelines. There are also the KDIGO guidelines, which we not infrequently refer to and follow. And they actually recommend that all CKD patients, like our patient, including diabetics, get a target of less than 120 on 80. But if you read the fine print of the 2021 KDIGO guidelines, which I'm sure you all have, they are the first to say that this recommendation is not based on trial evidence. It's an expert consensus recommendation. And I always like to remind folks of what the sprint population is, because it's relevant for this presentation. So there are people over 50 with hypertension, and they need to have cardiovascular disease or CKD, non-proteinuric, higher Framingham risk, and be over 75 years old. So most patients that we take care of in geriatrics, just based on their age alone, if they have high blood pressure, they'd be counted as high risk, but then they often get excluded because of CKD or diabetes, who are not included in SPRINT. Okay, so this slide is for your reference. I know it's not a pretty presentation slide, and I hate to be that person, but here I am. So just going through the evidence for blood pressure control in older adults, the kind of main trials that we think about and that the guidelines are based on. So the ACCORD trial, this was published before I entered medical school, but some of you may recall it. They had about 5 years of follow-up in people who were younger, just 55 plus, with diabetes, and they did not find a significant benefit, so p-value of 0.2 to intensive versus standard blood pressure control. And then, but they did have a number needed to harm of 49. So, and they of note excluded people who had a creatinine greater than 132, which is tough, right? Because I mean, treating hypertension and diabetics, like diabetes and hypertension kind of often move together. So it's a rough exclusion to make there. And then SPRINT, this is the trial that we all know and love. It came out in 2015. We all cheered. And this is what most of our guidelines are based on now. So we already went through who the criteria or who got into SPRINT. And SPRINT was significant because they found that the intensive control was associated with reduction in this composite cardiac or cardiovascular outcome with a number needed to treat of 63. And they didn't find a difference in the composite of serious adverse events, but they did have increased risk of hypotension with a number needed to harm, I think, around 90. But of course, they excluded people with stroke and diabetes, which is what we've all been kind of troubled by since. Sub-analysis of the SPRINT data, SPRINT elderly, was also published in 2015. And they had the same composite outcome as SPRINT, but they actually found, and I just include here, I should have done this for all the trials. It occurred to me late in the day, but the target was less than 120 versus less than 140, but these are the blood pressures they actually achieve. So 123 versus 135, which is relevant, as we'll see in subsequent slides. Their number needed to treat was only 27, with a number needed to treat for reduction in all-cause mortality of 41. And they also found increased harms, the same harms that we'll see across all of these trials, like hypotension, syncope, in people who were in the intensive treatment arm, but it actually didn't reach statistical significance, which is nice, right? Like a lower number needed to treat and not significantly increased harms. Sprint elderly is an important trial for us, I think. And then there was the RESPECT trial. So the RESPECT trial it was looking at specifically people with stroke, and it looked at people aged 50 to 85 and whether or not this intensive blood pressure control was associated with reduced risk of recurrent stroke. Unfortunately, they did not really achieve their treatment target in the intervention group. So you can see they achieved BP of 127 on 77 in the intervention group versus 133 on 78 in the standard control group. So not surprisingly, they did not find a significant difference in clinical outcomes, but one could, and many have argued, well, their blood pressures were not that different throughout the trial period. And then they did some fancy statistics. They pooled their data with 3 other RCTs, and they found a number needed to treat of 67 for this outcome. Take that as you will. And then I want to highlight Sprint Mind. There was a great presentation on this by Chandy in March of last year, so I won't belabor the point. This is the same Sprint population that we know and love from other Sprint trials. But they looked at whether this intensive control was associated with cognitive outcomes, and there was a significant protective effect found for the combined outcome and for MCI, but you can see the confidence interval crosses 1 for probable dementia. And then finally, the STEP trial also came out of our colleagues in China, their group there, and they looked at older adults aged 60 to 80, and they targeted a range of SVPs, 110 to 130 versus 130 to 150. But they excluded people with past stroke and diabetes with an A1C greater than 8. So they did find a protective effect of the more intensive blood pressure control to less than 130. However, similar to Sprint, they excluded a lot of folks that look like our patients. So this question, the ESPRI trial, as I have elected to call it, they wanted to know, does this intensive blood pressure control less than 120 versus 140 in patients with high cardiovascular risk and either stroke or type 2 diabetes reduce their risk of cardiovascular events and deaths? So really getting at the fact that so many of these trials have excluded people with stroke and type 2 diabetes. And let's find out once and for all if we should be targeting this more aggressive systolic blood pressure of 120. So this is their PICO. So I'll draw your attention to the P. Their age is 50 plus, so that's not unlike Sprint. Hypertensive, yes. And then their age cutoffs for high risk are actually a bit lower than Sprint. You'll remember Sprint, it was 75 plus. Here it's 60 plus in men, 65 plus in women. And prior cardiac disease or any of these many cardiac risk factors, including type 2 diabetes and stroke. The intervention was an SVP less than 120, and part of their protocol was that you start with 2 antihypertensives, so dual therapy to achieve this goal. Targeting an SVP less than 140 is standard, and then their outcome was standard composite of MI with or without revascularization, hospitalization or ED visit for heart failure, as well as stroke and cardiac death. And that was ascertained by patient report and then verified by 2 independent individuals. They had a secondary outcome. Obviously, components of the primary outcome were analyzed, as was death from any cause, and a composite renal outcome, which will become important later because this was an outcome of renal harms. And then they sort of teased that they also looked at cognitive outcomes, which would obviously be interesting to us, and fundus vascular outcomes, but those are not published in this study. Those are forthcoming, or maybe have been published. I'm not aware, but it's not in this study. And then here's the long list of people they excluded. So having a known secondary cause of hypertension is reasonable. Standing systolic blood pressure less than 110, reasonable, similar to SPRINT. And then you can't have had basically an exacerbation of any of these vascular risk factors in the past 3 months. That's tricky, right? Because a lot of times we see people in clinic because they've presented to hospital with something. They can't have PCI or CABG scheduled for the next 6 months. And then they can't have had heart failure exacerbation in the past 6 months. They have to have an LVF greater than 35. And this is a new one. They excluded people with an eGFR less than 45. You'll recall from SPRINT, you weren't included if your eGFR was less than 20. This was done because SPRINT sub-analyses that came out, or subgroup analysis that came out after SPRINT, demonstrated that people with an eGFR less than 45 actually benefited a lot less from intensive blood pressure control. So for ESPRI, they were like, let's just cut them. And then if you have a survival anticipated less than 3 years, which we in Geri often will do this calculation with great prognostic indicators, transplant recipients, and then they had active alcohol or substance abuse. I don't abuse, I think that's kind of an outdated term, during the past 12 months. And I like scoured their protocol and their appendix, and I could not find how they defined this, which frustrated me because a lot of patients that we see use alcohol and substances, and it would be useful to know who got excluded and why. So it was an open label RCT. They had 116 sites. Some of them were in community centers, and then there was online central randomization, so good automated randomization process. And then they had follow-up visits at 1, 2, 3 months, and then Q3 months, and then as needed to titrate blood pressure. It's unclear to me how these as needed visits came to be scheduled. And it did affect the results, and I will talk about how when we go through the results, that this trial started in 2020. So their first 3 months of randomization coincided with January of 2020, which you'll recall was a time when not many people were excitedly rushing to the hospital or to see healthcare providers in person. So 20 to 30% of their initial follow-up visits were done by phone, and that affected their ability to titrate blood pressure medications per protocol. Their blood pressure measurement was, I think, it's realistic. This is something we could replicate. We don't often, but it's they measured after 5 minutes of quiet rest. They used an automated cuff, and they just took a mean of 3 measures that went Q 1 minute. And they provided the medications free of charge. It was prescriber's choice which antihypertensives they used. They did an intention to treat analysis using Kaplan-Meier estimates, and then they did Cox proportional hazards for their regression. They had a priori subgroup, so that's nice. Like they thought about this, and it wasn't an add-on. I think these are all reasonable subgroups. And then, but it was powered to detect a 20% difference just in the primary outcome, so not powered to detect differences in these subgroups. And they also did very reasonable sensitivity analysis to account for competing risk of non-cardiovascular death in their outcome. This is the study flow chart. So you can see 16,000 people were assessed. About 11,000 people were enrolled and randomly assigned, again, between September 2019 and July 2020. These were tough times in healthcare. I want to highlight the fact that among those randomized to each intervention, so the baseline blood pressure is actually quite low, in my opinion. So they're 147 versus 147 as hypertensive individuals who were going to get this treatment. And then 127 people discontinued the intervention in the intervention group versus only 35 in the control group. Miraculously, only 6 of over 11,000 people were lost to follow-up over 3.5 years. So kudos to these investigators. And then in terms of who was actually in the sample, their mean age was 65. About a quarter of them were our favorite demographic, over the age of 70. 40% of them were women, around 38% had diabetes, around 29% had CAD, and around 27% had a history of stroke. So blood pressure was lowered. They achieved the first thing that we saw some of the earlier trials didn't, which was that you can see this is the standard group. So the standard group got down to a mean systolic pressure of 138 within 2 months. So you can see they got down here quite quickly, where the x-axis is time, y-axis is systolic blood pressure. And like I alluded to before, it was tougher to get the intervention group down to their target range, just because COVID, the first, was happening here, and that made it more challenging to titrate. But they did get down to the target range within 9 months. And they did so with a mean of about 3 medications in the intensive treatment group and about 2 medications in the standard treatment group. So the good news is morbidity and mortality were also lowered slightly. So they followed for a median of 3.4 years. And this composite cardiovascular outcome occurred in 9.7% of the control group, or sorry, in the intervention group, and 11.1% in the standard therapy group. This is a hazard ratio from the Cox model. You can see they're just squeaking into statistical significance with that confidence interval ending with 0.99 and a p-value of 0.028. So it is statistically significant just by a hair. And their number needed to treat is 71 people treated over 3 years to achieve one reduction, one person not having this outcome. And then I just want to flag for you that most of the reduced risk happened after 1 year. So you can see the lines are pretty much aligned here up until the 12-month mark, and then they start to separate with fewer outcomes in the intervention group and slightly more outcomes in the standard care group. And you can see they had to modify their scale here to make this difference visible, because in a non-modified scale, it looks like it's quite a marginal separation. And I think this again relates to the fact that they couldn't really reach their target blood pressure until 9 months in the intervention group. And always good to look at the composite outcome. You can see that the reduction in the overall composite outcome was based on reduced risk of stroke, death from cardiovascular causes, and heart failure in the intensive treatment group. And so they did many subgroup analyses. Like I said, these were a priori. These are some ones where there was a non-significant improvement in the composite outcome among the intervention group. So in all of these subgroups, that significant morbidity mortality benefit that they found in the overall analysis was not replicated. And I just flag our 70+ cohort because this is our favorite cohort, but also not statistically significant in people with diabetes or stroke, which is unfortunate because those were the subgroups that were kind of the crux of why this study was important. And then some significant subgroup, and just to flag, like, it's not surprising that these were not statistically significant, right? Like, we just scraped by with a 99% or like a confidence interval ending with 0.99 for our main analysis. So as soon as you split those numbers up, it's going to be very hard to achieve statistical significance by, like, you have a reduced sample size. Even so, there was a statistically significant reduction in the primary outcome in people who were former smokers, did not drink, and had a baseline BP of 141 to 150. So these people seem to be doing pretty well from a non-pharmacologic perspective, and maybe they just needed that extra boost in cardiovascular protection from the intervention. So unfortunately, harms also increased with this intervention. The thing that really struck me was they said serious adverse events occurred in 42% of patients in the intensive versus standard treatment group. And I was like, 42%, like we shouldn't be controlling blood pressure at all. But when you actually look at like what drove those like serious adverse events, it was hyperkalemia was the largest contributor. And there was no difference in hyperkalemia across the two groups, and also hyponatremia, which the people in the intervention group were at a higher risk of hyponatremia, although I'll highlight that the people in the intervention group were disproportionately, like by the end of the study, more than 50% of them were on diuretics, often thiazides, versus only 15% of the standard treatment group. So I think that's probably what's driving that. Same with hypotension and syncope. So not super common, but more prevalent in people in the intervention group. And again, they were disproportionately on thiazides. And we know at least one more medication than their friends over in the standard treatment group. And then a fairly low rate of injurious falls, which is nice from a geriatrics perspective. They also had this composite renal outcome, which I flagged for you earlier in the talk, and that is developing end-stage renal disease, having a sustained decline into eGFR less than 10, or a sustained decrease in eGFR to less than 40% of baseline, or death from renal disease, which is obviously undesirable. And this outcome only happened in 3%, or sorry, in 1.7% of the people in the standard treatment group, but happened in 3% of people in the intensive control group, with a number needed to harm of 78. And then the number needed to harm for syncope was 333. Just to like put this into context, like if you look at like the main results from the SPRINT trial, like their number needed to treat was 61 or 60 something versus our 71 in this trial. And their number needed to harm for syncope was 90-ish, I think. But the way that they're detecting syncope was unfortunately, like in this study, they had syncope reported by patients, but then syncope resulting in emergency room visit. And I imagine that that would be just generally underreported in this study, again, because fewer people who didn't have COVID were going to the emergency department in the early 2020s. So people might be less likely to go to the ED with syncope because they were afraid of getting COVID. So I applied the Oxford critical appraisal questions, and just like this is my opinion. Does the study address a clearly focused question? I say sort of, like they have a very clear rationale for why we need to attend to and include people who have stroke and diabetes, but then their subgroup analyses weren't powered to detect differences in stroke and diabetes. And I think so they asked a good question, but then like that wasn't actually the question that Feely answered. And then good research methodology, and obviously patients were not blinded to whether they were having their blood pressure intensely controlled, and neither were the people assessing them in clinic, but the people adjudicating outcomes were blinded. And then how large was the treatment effect? A 1.4% absolute risk reduction over 3 years. The confidence interval is it's fairly narrow, but like I said, remarkably close to 1. And then this, I guess, like spoiler alert, be my opinion, will the potential benefits of treatment outweigh the potential harms of treatment for my patient? I say not likely, with a number needed to treat of 71 and a number needed to harm of 78. It's not a super desirable looking intervention from my perspective. And then the risk of bias, I have the full risk of bias assessment in the appendix for your review, but really only high risk of bias in assignment to intervention because it was not blinded, and effective hearing to intervention because there was more dropout among the intervention group than the control, but the rest of the study had fairly low risk of bias per the Cochrane tool. Some strengths and limitations. So strength is that they included people with past diabetes and stroke. So like that's what we wanted here. They also achieved the target blood pressures in the intervention and standard treatment group for the majority of the study. a remarkably low loss to follow-up, only 6 people of over 11,000 over 3.5 years, and relatively low risk of bias. Some limitations, they compared less than 120 to 140. If you think back to our case and the guidelines that we typically apply in practice, like our question is typically more like 120 versus 130, which I understand is quite a nuanced difference. And they weren't powered to detect these differences in subgroups, which I would have liked. I already mentioned they didn't really clearly define relevant exclusion criteria. And baseline comorbidities, even ones like I think are relatively important for the study, like diabetes, were self-reported, and they actually weren't based on an A1C of any cut point. And they're high risk individuals, they weren't quite the same as sprint, which we already talked about, but it would just be useful for me because we use the sprint cohort to identify high risk people in our guidelines if they had replicated that high risk population and their study. And then we talked about how maybe their outcomes were affected by the fact that they were measured during COVID, in the early COVID pandemic, when we know people were not presenting to hospital as much with serious illness. There are lots of great studies out of Ontario demonstrating that. So in terms of generalizability, I will flag that the baseline blood pressures in these individuals were in the high 140s. And oftentimes, when I see people with blood pressure in the high 140s, especially in clinic, in part because I don't use the same, I don't do the 5-minute rest and then mean of 3 measurements, which I should. When I see someone in the high 140s, I'm like, oh, that's probably just white coat to some extent. So I'm not sure that their population is one that looks like mine, in part because I don't measure blood pressure like they do. And then they excluded a lot of people who I think look like our patients, really, especially those people with EGFR less than 45, and any recent vascular disease exacerbation, which again, it's what often brings people to our, yes, thank you, Dr. Goldlist. If you do a MOCA, that will increase blood pressure. Exactly. I sometimes tally my MOCA while I'm measuring their blood pressure, which I'm sure I've thought about often. That's not going to lower their blood pressure to see me ticking away at their MOCA. So, and then I do think that they had a reasonable intervention though, just in terms of the follow-up. This is not different from what our hypertension guidelines recommend. Our guidelines say you should be doing Q1 month monitoring when you're titrating medications for blood pressure. So that actually felt quite reasonable. So this is my summary for those of you just joining now. This was a RCT with an N of about 1,000. It looked at differences in this composite outcome of cardiovascular outcomes over 3.4 years. The people were around 65 years old. They had high cardiovascular risk, and 38% of them had diabetes, 27% had stroke. They found that this SBP target less than 120 was associated with a slightly lower incidence of their outcome than the standard target. And I've already flagged that number needed to treat of 71, number needed to harm of 78, and the inadequate power to detect effect sizes in stroke and diabetes subgroups. Okay, so I'm going to return to the case. I hope that after this talk, we're all reminded and know what we would do based on the Canadian guidelines and our clinical experience. And I invite you to think about whether or not you would change your management based on the ESPRI trial results. I will share my opinion, which I don't know, maybe it'll be controversial, and then I'd love to hear yours. So I say no. I would suggest this patient target an SBP less than 130 per the guidelines. I'm not convinced by this trial that the cardiovascular benefits of SBP less than 120 outweigh the harms in people with diabetes and past stroke. I would counsel the patient regarding the findings of the SPRINT MIND trial, although she already has mild cognitive impairment. And so the aggressive blood pressure control might be of less benefit to her. And then the guidelines recommend first line add-on thiazide therapy in people with CKD, like our patient. But I think I and many of you might actually reach for a long-acting DHP calcium channel blocker like amlodipine, just because we know there's a 6% hyponatremia risk with thiazide therapy in older adults. So that would be my take. I see Dr. Goldlist has a raised hand. Oh yeah, and then I also just so this is my take, and this is my question to the group, and then Dr. Goldlist, I'd love to hear from you. Do we need more trials examining hypertension targets in people with diabetes and past stroke, or is this it? Are we satisfied? I have an opinion. What is yours, please, Dr. Goldlist?
Thanks very much, Natasha. Beautifully presented, and really reflects your nuanced understanding of the issue, not just the critical appraisal of the trial. So thank you for that. Go ahead, Barry.
A question and then a couple of comments. The question is, the slide went by too quickly for me to see whether all-cause mortality was different in the two groups. I saw the cardiovascular was. The comments are one that, the falls numbers are almost certainly prone to error. We know from prospective studies going back 40 years that when people retroactively remember their falls, they dramatically underestimate them. So it's probably much more. And then the thing that I think from a practical point of view for a geriatrician, maybe we need to do it the reverse way, not who needs to be treated for more aggressively, but say that lowering the blood pressure to 120 is generally a good thing. Who shouldn't we do it to? Who's going to not benefit from it? And look at that side. From a geriatrician's point of view, we probably have very few people who will tolerate having their blood pressure 120. So it's more relevant to other kinds of physicians, but we're still supposed to be the standard bearers of discussing it. So I think we need more data on who not to treat so aggressively so that we don't cause the harms.
I agree. And just to answer your question, it looks like all-cause mortality was very, very slightly lower in the intensive treatment group.
Thank you, Gary. Just before we get to your hand, Christina has a comment in the chat box related to external generalizability. It would have been nice to know the level of frailty in this population. They seemed well overall, but I don't think they had a specific frailty measure. Much
No,
like
they
the
did not.
Sprint Senior did. Yeah.
They did not. That's a great point.
Good point.
Thank
Go
you,
ahead,
Dr.
Gary.
Marcus.
Loved your presentation, Natasha. Thank you.
Thank you.
So just wanted a couple comments. When you look at the subgroup analyses, and I know although several of them were not statistically significant, notably almost all of them, the point estimate is in the direction of benefit. So I don't think we should exclude that. The other thing is, my understanding is the best way to look at subgroups is to look at the difference of differences rather than to repeat the analysis of the endpoints in the two groups. And this looks like they looked, again, repeated the analysis, but just in the subgroup. So I urge some caution because I believe that the gold standard is looking at the difference of differences of the subgroup versus the primary analysis group for that. The other question I'd ask you, because I really love the way you presented this. Do you feel, because you basically said the number needed to treat, number needed to harm, which was kidney related outcomes, were basically the same. But do you believe that the benefits group of things is of similar import to the harms, the kidney harms, I guess?
Yeah, that's I thought long and hard about this. And first of all, I appreciate your point regarding the subgroup analysis. And they actually flag like they do their subgroup analysis like this, and they're like, by the way, like we didn't adjust for multiple comparisons. So like beware, but it's still the data that they presented. And then regarding the kidney outcomes, so I think that it would be first of all like a patient choice. I will say that among the people who experience that eGFR decrease by 40% or more, most of those people were starting with relatively normal renal function. If you think about it, like they excluded people who had bad kidney function at the start. So I think like some of those people could have they could kind of like take a hit from a renal perspective and still not like be on dialysis. And so I think if you ask most people, like, would you rather die from a heart attack or like have CKD? Like they'd rather have CKD. I think the fact that they excluded people who have CKD makes it hard for us to extrapolate whether the harm would actually put a lot of people on dialysis if we applied these findings to people with any sort of baseline kidney disease. So an answer, no, I think or yes, I think the benefit is probably slightly greater than the harm, but not in a way that I find overly convincing. Yeah.
Jennifer has, thank you. Jennifer has her hand up. Go ahead, Jen.
And you're muted if you're talking.
Yeah. Jen, you're still muted.
Oh, hi there. Okay, can you hear me now?
Yeah.
Yes.
Okay, great. Sorry, I don't have my camera on because Dane is sitting here with me. Just to add on to Dr. Nagley's point about the interpretation actually of this slide, I agree with what he said, that, if we look at the adjusted p-values showing the effect modification, like I would say, like he said, it looks like all the hazard ratios, have sort of a trend towards, or, they're in the direction of benefit, but it wouldn't appear to me that you would say like age is an effect modifier. It looks like it isn't, because, based on the statistical test that they applied, there's no sort of effect modifying effect of age, for example, or the other groups. And just sort of crudely, you could look at that by seeing like all the confidence intervals sort of appear like overlapping, right, of the different effect estimates. So just like by eye, I would have said the same thing, that like age, for example, doesn't appear to be an effect modifier. So that was all I wanted to add. Great job, Natasha.
Thank you, Jen. Go ahead, Barry.
This is just a general question for the researchers. How do participants in trials value composite outcomes, which is a hard thing for a person, it seems to me, to understand, versus, death, heart attack. I understand the reason for the composite outcomes, but I just wonder how participants value them and understand them.
I invite any trialists in the room to comment. I am not a trialist.
Does anyone want to field that question?
Well, as Barry knows, it's a power issue. So composite outcomes are always preferred by the trialist because it reduces the total number that you need to show differences. And that's why they end up doing these subgroup analyses to give you a sense, if you have a positive outcome, which were the outcomes that sort of contributed to the fact that it was beneficial, and then I guess you can make that judgment. But of course, Barry, to explain this to patients and give them this bunch of possible outcomes is more difficult for them to maybe clearly understand. So it's the old story is when you're a trialist, you're trying to get a positive trial and a claim to fame. When you're a patient, it'd be a lot more clear if you could tell them about specific outcomes, individual outcomes, rather than a cluster of outcomes.
Thank you. Karen, go ahead.
Thanks, Natasha, for a really nice presentation. I enjoyed it. I would just want to make a comment that it would be really nice in the trials to see a measurement of orthostatic hypotension along with their measurements of hypertension and their blood pressure measurements over time, because to me, even though we do see the falls outcomes in the presentation with syncope, we know that there are so many patients that will have orthostatic hypotension. It's in the normal population, it's about 20% in over 65. And then on top of that, with medications and other problems and dehydration, it's going to be higher. So I think and we also know that the patients that present to the emergency department and are found to have syncope are underestimates of what actually we see as being, sometimes they're labeled as falls, but they actually did have pre-syncope or syncope. So I think in order to capture those patients, it's really helpful to actually get orthostatic hypotension, orthostatic vitals at every measurement to really be able to assess, is this a valuable outcome of reduction in blood pressure, because we know that it can be so influential for patients, and because we're actually measuring it in our clinic visits, whereas a lot of the specialists don't have time to, or aren't doing it correctly.
Yeah, so this study, I appreciate your comment, because I agree with you. We do clinic together. This study did not report on incidence of orthostatic hypotension. You can see they just report on hypotension, which is different. I will say that Sprint did do, and everyone maybe is aware, and it's old news, but Sprint did do a post hoc analysis of orthostatic hypotension. And in the post hoc analysis, which I feel like it published in like a medium good journal, probably a better journal than I've ever published in, but it showed that actually incidence of orthostatic hypotension was actually lower in the aggressive blood pressure control arm of Sprint. I haven't done like an in-depth analysis of those findings, but and I'm not sure if people have good explanations of that in their head, but the one large trial that did report on orthostatic hypotension remarkably found that it was reduced in their intensive arm. So take that as you may.
Thank you. And perhaps, Natasha, I can ask, what do you think is the mechanism why secondary stroke prevention with aggressive blood pressure control doesn't work, but it works for other high-risk situations?
Yeah, I'm not totally, I'll just go back to that slide. I'm not totally convinced that it doesn't work. Like looking at the Accord trial, or sorry, not the Accord trial, the Respect trial, which is maybe where we might draw that conclusion from, just with respect to the inefficacy of secondary stroke prevention with blood pressure control. They just did not achieve a really big difference in their intervention versus control group in the Respect trial. And so I actually wouldn't necessarily draw that conclusion yet. So maybe we do need another trial of that. But I'm just not convinced. Like this to me, like comparing people with 133 versus 127, not a physiologist, but that seems pretty similar to me. So
Go ahead,
I'm not,
Gary.
yeah.
Thanks. Go ahead, Gary.
Just to ask maybe a more generic question, sort of reflecting, we understand that for many people, ambulatory blood pressure monitoring gives a different result than their in-clinic assessment. And decisions are often made for those people based on the ambulatory blood pressure. So you're taking a very cross-sectional assessment of blood pressure. And a recent experience with a patient of mine where I had their retirement home nurse measure a series of orthostatic vitals over a period of 3 months, and seeing that, it was quite sporadic. Many of the readings, there was no orthostatic hypotension, but then there were intermittent readings that she had marked orthostatic hypotension. So I guess the generic question is, do these trials actually measure blood pressure in a way that we really have a good sense of what their blood pressure is over time, as opposed to just these snapshots in time.
I think it's like it's basically a question of like internal versus external validity. So I think a trial like this, I would agree with you, like the internal validity is kind of questionable, right? We don't like it is just an in-clinic measure. So and yes, we do know, and that's why the guidelines have different cutoffs for ambulatory 24-hour monitoring versus in clinic diagnoses of hypertension. So I think we're all aware of the limitations of in clinic monitoring, but I think from a generalizability perspective, I'm not sure I want a trial that measures blood pressure perfectly because I don't. And I think I'd find that those findings really hard to apply. So I think in this one area, I'd prefer the generalizability to the really excellent internal validity.
Thank you. We have a few minutes left. Any final question or comments? If not, I will thank Natasha very much for a beautifully presented journal club, and what a great way to set the standard for the or kickoff of the year, and a very rich discussion with a nuanced understanding. So thank you so much, Natasha. I echo Gary's applause, and some chats coming in, comments coming into the chat box. The evaluation should be coming to your inbox very soon. I'd like to remind everyone to complete your evaluations. It was lovely to see everyone this morning, and we look forward to next month's Journal Club. Thank you, everyone.
Thanks, folks.